and welcome to the FMG 2025 July month Psychiatry Recall session. First of all, I would like to congratulate all of you for showing up today, whether you are already written the exam or preparing for the next one. This session is a valuable step towards your goal for clearing FMG or your NEET PG or whatever exam it is confidently. I know how stressful recall session will be, but this one is special because here something I wanted to highlight at very beginning. Over 98% of the question in the July 2025 FMG exam were covered directly or indirectly in our classes at Dopamine Search as well as the Gorilla Medical Intensive Program. That includes the core concepts, clinical vignettes, and rapid revision sessions, and high yield tables, visual memories, and even obscure but predictable repeat areas. And that's where we stand. And so I have been attending the session, making notes, and even passively following along. You were more prepared than you realize. In today's session, we are going to revisit the actual recall questions from this session, provide you the correct answer with reasoning, rule out the distracting options because FMG or your NEET PG, they are often about choosing the right answer and ruling out the wrong answers. And I'll give you a smart tips for the similar questions that may appear again in your NEET PG exam or in your December FMG exam. By the end of the session, you will not only reinforce what you got right, but you will convert every miss into a lesson. So grab your notes and let's dive into the questions and back up with evidence, explain with the clarity and connect everything what you have already learned with whatever you're going to learn in future and whatever mistakes you have learned in the past. So coming back to the FMG recall questions, so as I have analyzed the paper, basics length they have asked one question and schizophrenia they have asked again one question. As I always repeat in my all my sessions, schizophrenia is again an important topic. Similarly, they have asked question from mood disorder again and substance use. Again, it is a very important. So you will definitely get a question, be it alcohol, be it a opioid, be it a cocaine or anything. One substance use will be there. And trauma disorders, I have last time when I took the GMI program, I have emphasized that trauma and the stressor related questions are repeatedly asked in nowadays in the exam, as well as dissociative disorder. This is something which is new. First time they have more concentrated asked directly into this dissociative disorder. So I think this is one thing maybe tricked you or maybe had a confusion. And as usual, they have asked one question from PSM and psychiatry correlation, and child psychiatry has been asked one question. So totally, if you see, almost 3, 6, 7, 8 questions have been asked in this FMG exam, and we are going to discuss one by one in detail. Are you guys ready? Yeah. So the first question. A person has a false belief that he has lots of property and is rich and somebody he knows wants to kill him and take away all the property with him. He appears depressed and physically unwell. What is seen here? So this is the question and the options given are delusion of grandeur and persecution, delusion of grandeur and reference, delusion of nihilism and delusion of grandeur and nihilism. So before starting with, I can tell you that this same question with some changes in the profession and something I have given you in your dopamine search program. So if you are a subscribed user of dopamine search program, you would have definitely attended this question very well because same question I have discussed already in the session. But again, I'll just give you a brief idea. See what they are asking. So there is a false belief. From this word false belief, you can understand that there is some delusion. Now coming to, he has lots of property and rich. That means there is a component of grandiosity in it. So that is a second thing. And he is also telling that somebody he knows wants to kill him. That means there is a component of persecution. So here what all you are going to see? You are seeing a component of grandiosity. You are seeing a component of persecution. So there is a delusion of grandiosity. There is a delusion of persecution. So these two are right. Delusion of grandiosity and delusion of persecution is right. But do you think there is a delusion of nihilism here? What is delusion of nihilism here? I have told you already in my session. Nihilism means what? The person will tell that everything is gone. His body is gone. His body is eaten up by someone. He is not having a body right now. He is not in this earth. So all these things, he will be like telling that he is not at all alive. All these things are called as the delusion of nihilism. So everything from him is lost. So these kind of thing is called delusion of nihilism. So it is not here. Similarly, delusion of reference. What is delusion of reference, guys? Delusion of reference means the person will tell that other people are talking about him. When I am going in a park, I am going in a road, I am seeing people are talking about me. People are talking ill about me. Is there any component in this question? No. So there is no delusion of reference. So the answer here is delusion of grandiosity and delusion of persecution. So as I told you, what is a delusion? Delusion is a false, fixed, firm belief held with an extraordinary conviction. Even if you try to explain him that his ideas are irrational, he will not accept it. Similarly, it is unexplained by cultural and social background. Clear, right? So these are the types of delusion. I think I have explained you in detail in the regular sessions. Delusion of persecution is the most common delusion. Delusion of reference means belief that external events are referring to him. The news anchor is talking about me. The people around me are talking about me. So what is a delusion of grandiosity? When the people think that they have extraordinary powers, they have extraordinary money with them, they are having extraordinary identities, they have very good importance in the society. All these things are called as delusion of grandiosity. And what is nihilistic delusion? The people will think that the world is not existing. So if this is accompanied by ideas of body decay, I have already told you that is called as Cotard syndrome. And you know what is a delusion of love? When somebody in the higher status are in love with them, if they are thinking, that is called as delusion of love. And what is Declambrate syndrome? When a woman believes a celebrity loves her, that is called as Declambrate syndrome. So similarly, there is a delusion of infidelity. Delusion of infidelity most common in alcoholic disorder. ADS patients, la most common delusion which you are going to find is delusion of infidelity. Similarly, Capgras syndrome, when there is going to be a familiar person replaced by an identical imposter, and Frigoli syndrome. So definitely what I can tell you is from this part. So when I call it as a basics, I mean two things. One is delusion and another is hallucination. From the delusion component and hallucination part and your MSc, between these three topics, definitely every exam will carry one question. That is why I have given importance in my dopamine surge regular classes on this basics. Okay, so you need to be thorough in the basics. So when you are thorough in the basics, this question is very simple. So out of the 100 people, those who are writing this exam, definitely 70 to 80% of people will be having a correct answer in this. So you should be very confident while attending this question. Now, coming to the second question. A 36-year-old presented with a hyperactivity again. So hyperactivity, reduced need for sleep, excessive spending. So what is the answer do you think? While seeing this question itself, patient is having hyperactivity. Patient is having hyperactivity and there is a reduced need for sleep and excessive spending over the past 2 weeks. When you question them, patient is telling that, no, I am not, and she is irritable and anger outburst is there. What is the mostly diagnosis? On seeing this question itself, what I can understand is patient is having hyperactivity, reduced need for sleep, increased energy, increased PMA, psychomotor activity, excessive spending, over religiosity, over activity, over talkativeness. All these things are component of what condition? Do you remember, guys? Yes, the answer is mania. So now you know the answer is mania. But you need to differentiate whether it is a mania or hypomania. So how do you differentiate? When I tell that the symptoms are lasting just for 4 days, then you call it as hypomania. Similarly, when you call it as mania, when these symptoms are lasting for more than 2 weeks, you call it as hypomania. Okay, so you call it as mania. When it is more than 2 weeks, you call it as mania. When it is less than 2 weeks, more than 4 days, you call it as hypomania. Is it clear, right? So this is what I wanted to emphasize here. So the answer for this question, whether it is bipolar 1 disorder with manic episode, bipolar 1 disorder with hypomanic episode, what is the answer here? Exactly, the answer is bipolar 1 disorder with manic episode. So you need to understand this simple diagram which I have given already in my previous classes. See, how do you differentiate between bipolar 1 and bipolar 2? So this question does not give you anything regarding depression or anything regarding recurrent depression or any depressive episode. But the option is not having just mania. So you need to choose between the two because it is not schizophrenia, you know that, and it is not cyclothymia, you know that. So the option between them is these two. So when you have these two, you don't think about why is it depression, is it bipolar 1, bipolar 2. We don't need that. We know only it is a manic episode. We are confirmed with that. So option A, B is the right answer. But when you discuss about the ruling out the other option, you need to understand one thing. So what is a bipolar 1 and bipolar 2? When do you call it as a bipolar 1? When there is a definite manic episode along with the depression, you call it as bipolar 1. Whereas in bipolar 2, you will not have definitive manic episode, but you will definitely have a hypomania along with depression. So depression along with hypomania, you call it as bipolar 2. Depression along with mania, you call it as bipolar 1. Okay, so when you have a depression after a manic episode, you call it as bipolar depression. So this is what I want you to remember. So now coming back to the mania. So a brief introduction about the mania or just a revision. So mania, what are the things you will definitely have? There will be an elevation in the mood. Hyperactivity will be there. There will be increased energy. There will be a flight of ideas, overactivity, reduced need for sleep, over talkativeness, impulsivity, grandiosity, and distractibility. All these are the components of mania. And how will you diagnose a mania? You should definitely have a mood elevation, number one. Number two, you should definitely have increased energy. Along with this, other options like any three has to be there. In other symptoms, any three has to be there. Regarding mania, guys, what you need to understand is male are more prone for mania than female, and it is most common in the psychosocial issues, like if there is going to be any divorced male or a single person, low socioeconomic status. All these are bad prognostic factor as well as the etiological factors of a schizophrenia, mania, and all the psychotic disorders and mood disorders. Okay, and duration of mania is 1 week. As I told you, to call it as hypomania, so you should have at least for 4 days the symptom has to be persisting, and these symptoms must not be severe enough to impair the functioning of the person. So he will be telling, sir, I am over talkative compared to before, but I am able to do my regular day-to-day job. I am able to do function regularly. So that is called as hypomania. And there is no flight of ideas or no psychotic symptoms, and patient will never get hospitalized. Now coming to the next question. A man came with a bizarre presentation to hospital. Some collateral person gave a history of recent earthquake few months back, and the person neither remembers personal information nor he came to hospital that is 100 kilometers away from his home. What is the likely diagnosis? The option given is dissociative amnesia, identity disorder, schizophrenia, and global amnesia. First thing what we can see is schizophrenia. Is this a presentation of schizophrenia? Definitely no, because there is no delusions, there is no hallucination, there is no organized the disorganization of his thoughts. So definitely it is not schizophrenia. So now you have remaining three options with you. One is dissociative amnesia, identity disorder, and global amnesia. So what do you guys think it as answer, or what you guys attended in your exam? Yeah, so the answer is dissociative amnesia. I'll explain you why it is. So what is a dissociative amnesia? It is the inability to recall about the information on that person, like autobiographical information you will be forgetting. Usually it will be followed by some traumatic or stressful condition, and which will be inconsistent with ordinary forgetting. So it may include dissociative fugue. What is dissociative fugue? It is nothing but when the dissociative amnesia person travels or wanders away with confusion about his identity, then you call it as a dissociative fugue. So actual option it should have been is dissociative fugue, but then dissociative amnesia is right answer. Why? Because your dissociative amnesia is of four types basically. The localized amnesia, selective amnesia, generalized amnesia, and dissociative fugue. Let's see one by one. Before that, what is the diagnostic criteria of dissociative fugue? What does the DSM criteria tells? Inability to recall important autobiographical information. This is the exact line given in your question, isn't it? And it is going to be following some traumatic or stressful events. So that is your earthquake which they have given. And they have to have a significant impairment in the social occupational functioning, and this should not be attributed some physiological effects like your alcohol use, any drug abuse, or the normal medical conditions like global amnesia, traumatic brain injury. If the same question gives you that the patient had a head injury, afterwards the patient had a forgetfulness and all these symptoms, then definitely it is not dissociative amnesia. And this disturbance must not be explained by other dissociative conditions like your personality conditions, identity disorders, post-traumatic stress disorder, acute stress disorder, any somatic symptom disorder. All this should not explain this condition. Then you can call it as a dissociative amnesia. And when do you call it as dissociative fugue, which is separated and given as 44.1 in your DSM criteria, where all this dissociative amnesia symptom will also include the person traveling or wandering without any purpose. Without any purpose. So this is called as dissociative fugue. So there are four types of dissociative amnesia basically: localized amnesia, then selective amnesia, generalized amnesia, and you have a dissociative fugue. What is localized amnesia? Inability to recall all the events during a specific period of time, and it will be usually related to trauma. But then here what happens? The person will not be wandering around like in dissociative fugue. Whereas what is a selective amnesia? He will be able to recall some events, but not all events during that particular specific timing. Like a soldier remembering fighting in the war, but he does not remember that his friend has died and he has seen it. So that is selective amnesia. What is a generalized amnesia? Complete loss of memory of entire life history. And dissociative fugue means unexpected travel away from home with inability to recall past and some confusions about his identity. Clear? So the answer for this question is dissociative fugue. So other options, why it is not there? As I already told you, schizophrenia should never be your option. Transient global amnesia, yes, again memory loss can be there, but anterograde memory loss can be there. And there will no chance of identity confusion, sudden travel or hallucination, delusion, all these things will not be there. And it also can have a trigger of physical exertion or stress, but it will be brief, whereas this can be months to days to months. It can be like prolonged and it can be longer. Okay, now coming towards the next one, next question. A patient with schizophrenia developed a muscular dystonia and was treated for it. Okay, yes. So this is nothing but the side effects of the drugs which we give, antipsychotics which we give. So there can be any antipsychotic could have been given to this patient, schizophrenia patient. So they are not asking about that. They have given some drug and muscular dystonia happened, right? Now the patient is complaining of dry mouth, dizziness and hypotension. What does that mean? So some antipsychotic was going for this patient, and after the antipsychotic was given to the patient had some EPS symptoms like acute dystonia. And now what the question tells us, to treat the acute dystonia, they have given some drug X. We don't know what drug it is. But after giving this drug X, what happened? There is some dry mouth, there is some dizziness. Okay, there is some dry mouth, there is some dizziness, and there is some hypotension. So this is the question that gives you. Now you have to identify what is this drug X. Risperidone, haloperidol, they are actually antipsychotic. Definitely, they would have not been given for a patient to treat muscular dystonia. So option B and option C is ruled out. Now you have option A and option D. So in this, they have given dry mouth, dizziness, hypotension. All these things are what? Can you guys guess? What are they? What are they? Any idea? Any idea? Yeah. So we will see about it. Okay. So what is this condition basically called as? What is this condition? So the patient had a acute dystonia. Acute dystonia is nothing but it is a extrapyramidal symptom. Okay. Now coming towards the next question. There are four options given: benztropine, risperidone, haloperidol, propranolol. Risperidone and haloperidol, as I told you, it is like an exclusion because they cause EPS. Your haloperidol is the one that causes dystonia, extrapyramidal symptoms, neuroleptic malignant syndrome. Okay, so they are not given for treating the dystonia. So definitely option B and C is ruled out. Option A is benztropine. What is a benztropine? Benztropine is an anticholinergic. So you know that whenever you are going to give an anticholinergic, they are going to cause side effects like dry mouth, blood vision, dizziness and hypotension, urinary retention and all these things. So the option A, benztropine is the right answer. But why not propranolol? You know that what is the side effect of propranolol? Propranolol is a beta blocker. What does the beta blocker does? Beta blocker causes bradycardia and hypotension, but it does not cause dry mouth. Okay, hypotension may be there, but anticholinergic side effects like your dry mouth, dizziness, blurred vision, all these things will not be present in in your propranolol. So propranolol is also not a right answer. So the best option here is benztropine. So now to briefly recall all the extrapyramidal symptoms and all the side effects of antipsychotic drugs. So acute dystonia occurs from hours to 3 days. What is the dystonia? Sudden contraction of muscle, sustained contraction of muscle. Usually this occurs in the neck region, but it can also occur in the limbs. It can also occur at any muscles which is present. So it can be presenting as torticollis, oculogyric crisis when the oculomotor muscles gets spasm, or laryngospasm, which is very rare, but it is an emergency condition. So what do you do then? So in that case, you will give diphenhydramine or promethazine as a parenteral, whereas benztropine can be given as oral drugs to ensure that the patient does not go into extrapyramidal symptom in the future. And akathisia means restlessness, inner restlessness. The patient will be unable to sit. They will be pacing around your ward. So for that akathisia, the drug of choice is propranolol. So propranolol is drug of choice for akathisia. It is not a drug of choice for your dystonia. So that you need to understand. So when you understand that, propranolol can also be easily ruled out. So the best answer is acute dystonia. Okay. Now coming to pseudo Parkinsonism, what happens? It can develop in a weeks. So basically the patient will have all the features of Parkinson's like bradykinesia, tremor, rigidity, masked faces, all these things. So what will be your drug of choice? Again, benztropine is going to be your drug of choice over there also, because you need to administer anticholinergic for the patients. Tardive dyskinesia, again, we decide involuntary movements like lip smacking, trunk protrusion, choriothetoid movement, all these things. So what will be your drug of choice? So you will switch to valbenazine, and you will stop your avoid anticholinergic in the patient and avoid all the antipsychotic which is causing. Start with valbenazine. It's a VMAT vesicular monotransporter inhibitor, and then you shift the patient to clozapine, which is not going to have the side effect or least side effect profile, and it will help the patient to get stabilized. And finally, neuroleptic malignant syndrome. It can occur anytime like fever, rigidity, autonomic instability, or delirium like threatening conditions. All this can occur. And in this patient, you need to stop antipsychotic primarily and start with dantrolene and bromocriptine. And the patient must be kept in the ICU and monitor vitals and monitor all the essential things so that the patient doesn't move into neuroleptic malignant syndrome. And most probably what probably will occur in future is there will be a rhabdomyolysis which can also occur in this patient. That is why you also have to monitor CPK value. Clear? Next. Moving towards the next question. A 6-year-old child presented with a bedwetting. Which of the following is a treatment of choice? Can you guys guess the answer for this question? Is okay. Option A, behavior therapy. Option B, CBT. Option C, desmopressin. Or option D, imipramine. What is the answer? So desmopressin, imipramine is pharmacotherapy, and the first two is psychotherapy. So what is the best choice out of all these things? Yes, the answer is behavior therapy. So always remember that. Always remember that the patient coming with a nocturnal enuresis, the drug or the treatment of choice. If you ask me what is the treatment of choice, my option will always go to behavior therapy. My option will always go to behavior therapy. Why? You need to understand. See, all your desmopressin, imipramine, they are going to be second line of drugs. So second line. Why? Because the your behavior therapy is very effective, that you don't need to start with desmopressin, imipramine at the first line of choice. Okay, and coming to the CBT, CBT is not first line of choice for nocturnal enuresis. Okay, in children, it is actually used in adolescents where there is some emotional or behavioral issues. But this is not emotional and behavioral issues. And one thing you need to understand is when I tell behavior therapy. So what behavior therapy we use? We use something called as classical conditioning. Classical conditioning. So classical conditioning is nothing but we use bell and pad method. So sometimes they may give in you an exam directly as bell and pad. Sometimes they can give you as classical conditioning. Sometimes they can give you as behavior therapy. But at the end, The answer for the question asking as a drug of choice or the treatment of choice. Drug of choice means you need to go for the pharmacotherapy. When they ask you treatment of choice, then your option has to be behavioral therapy. In behavioral therapy, it is classical conditioning. In classical conditioning, it is a bell and pad method. Okay, it is most effective for treatment of enuresis. So it is proven that more than 50% of cases, bladder training will be effective when you do this bell and pad method. So CBT, again, as I told you, it is not first line of treatment for bedwetting in a children less than 10 years, 5 years, 6 years and all. You don't use CBT. Desmopressin is again the second line or drug of choice in case of a pharmacotherapy. Imipramine is nowadays used, but we are not using it as a immediate drug of choice because the problem is it's a tricyclic antidepressant and rarely it can cause cardiotoxicity or relapse after stopping. So we are reserving only in case of refractory cases. So from here what you understand is when they ask you treatment of choice, your answer has to be behavior therapy, classical conditioning, bell and pad method. In the out of these three options, one has to be there. And if they ask you specifically what is a drug of choice, then you go for desmopressin. If they ask you as a drug of choice, then go for desmopressin. So when I already told you what is a desmopressin, it is an antidiuretic compound. So this is going to reduce the enuresis by 10 to 90%. So that is why you desmopressin. But what are the desmopressin side effects? It can cause headache, nasal congestion, epistaxis and stomach ache. All these things can also occur. So that is other one problem of giving desmopressin. So now another new drug comes. I wanted to discuss about this also because in your NEET PG or the next FMG they can ask you this. What is this? Reboxetine. Reboxetine, it is a norepinephrine reuptake inhibitor and that this does not have a cardiotoxicity. So in the previous thing I told you, right, in your imipramine cardiotoxicity is there, but this is a non-cardiotoxic drug, so which can be used as an alternative for imipramine in the treatment of childhood enuresis. Okay, in the treatment of childhood enuresis, you can use this. So reboxetine, so this can be asked as a question. So new update, I want you to be thorough in this. So what is the new update, guys? Reboxetine, it is a norepinephrine reuptake inhibitor, which is going to be used as an alternative for imipramine. Why we are using it as alternative for imipramine? Because it does not have any side effects. Cardiotoxic side effect is not there. But nevertheless, when the question is asked, what is the first line of treatment? It is behavior therapy. What is the second line of treatment? It is desmopressin. What is the third line of treatment? It is imipramine. And CBT is not regularly used. Clear, right? Next, coming to the next question. This is sometimes I feel like they ask out of book. And this is like very easy question. You can just see the question and attend. So this is like asked in PSM. You can consider as a PSM question or your psychiatric question. So what is the question? Tells you a girl came with a history of schizophrenia to a primary health center. Which of the following is a tele mental health program provided by the government of India to deliver mental health care services via telephone and online application? If you have common sense for this question, 100% of people would have written this as right. Tele MANAS. What is Tele MANAS? Tele MANAS is a national health program which is mainly started by the Nimhans people, and they have started this initially, and now several initiatives by state governments, institutions, private bodies are also demonstrating advantage, and they are also adding up to the treatment effectiveness under Tele MANAS. Tele MANAS is nothing but a teleconsultation service which is started to enhance the health service capacity of mental health care through your tele mental health network support system. And this is mainly started to network the and find out the people, those who are having mental health issues, and to provide a grassroots healthcare services for the people who are suffering from mental health issues. And the force of Tele MANAS is nothing but the doctors from various deemed hospitals like your Nimhans, AIMS. They are recruited into Tele MANAS, and they provide services like psychiatric consultation along with counseling, including psychotherapy and pharmacotherapy is done. So this is one thing which is important. So what are the objectives of this? So main objective is to enhance the mental health services capacity and deliver accessible health care, mental health care for the people, and to ensure a continuity of services in the community and ensure a mental health care capacity and networking. Okay, this was actually launched in 10th October 2022, and it is effectively being run by state as well as the central government, as well as various central institutes are taking care of this Tele MANAS program. So this is the number. as a public health awareness, you guys also can spread the word to the people. If at all any people have suicidal tendency, if at all any people are depressed, they wanted to take opinion and they have the stigma to go to a doctor, they can approach the Tele MANAS and definitely you can get some help which you need. Okay, and regarding the other options, UWIN is a digital platform for universal immunization program. Nikshut is a digital reporting system under National Leprosy Eradication Program, and Niksha is under TB control app based or case web based program under your RNTCP. It was started and later now it is being run by NTEP, National Tuberculosis Elimination Program. So guys, coming to the next question, a 28-year-old software engineer visits a psychiatric clinic and he is suffering from sleep disturbance. So first they are giving patient is having a sleep disturbance and there is a low mood and stress in his current job for the past 3 months. He cannot work properly and he is having difficulty in balancing his family and work. That means he is having a stress of balancing the work-life balance and he is not having any prior psychiatric history. What is a likely diagnosis they are asking? So if it is, we have four options given here: adjustment disorder, generalized anxiety disorder, acute stress disorder, and post-traumatic stress disorder. So if it is going to be a generalized anxiety disorder, it shouldn't have any particular stressor in it. So this question, if it is going to be the generalized anxiety disorder as answer, no stressor should be there. The patient should be having disturbances in his mood, not than calling it as a mood. The patient will be having a fear always. So the fear of something is going to happen, some problem in his life. So if that is the case, then there is no stressor particularly. If stressor is there and a fear is there, then it is a panic attack. So generalized anxiety disorder is definitely not the answer. Acute stress disorder has to be less than 1 month. But here in the option they have given, the question they are given as past 3 months. So this is also not an option. Post-traumatic stress disorder. If it is a post-traumatic stress disorder, there has to be some life-threatening situation that had happened, following which the patient is having a low mood, reduced sleep, and all these things. And the patient will be to such that the patient will not be able to do a regular social and occupational functioning. But in this case, the patient is able to go to work, but he is having the stress because of which he is having a sleep disturbance, low mood, etc. So the answer best option will be adjustment disorder. What is the adjustment disorder? The patient must have a identifiable stress, like psychosocial issues has to be there, and the onset of symptom must be within 1 month of the stressful event, and there must be emotional or behavioral symptoms like low mood, anxiety, irritability, sleep issues. All these things has to be there, and severity of symptoms out of proportion. The patient will be having a stressor like this is, we may think that this is not at all a stress, work is there for everyone, then why the patient is having stress, we may think like that, but the patient will be taking that as an important stress, and because of which the patient will not be able to function well, and that is called as a out of proportion stress, and usually it resolves within 6 months. So 6 months is a duration time. If more than 6 months that stress is causing distress to the patient, then you call it as a depression, not an adjustment disorder. And the patient will have a social occupational impairment, yes, but it will not be severe enough to identify it as a psychiatric diagnosis, and it is not due to any mental disorder, substance or organic illness. So what you need to understand is adjustment disorder is something which you are going to see frequently in a hospitalized or in a medical surgical problems. When a patient is admitted in a general medicine, general surgery, after a surgery, patient will have a brief depressive reaction. So adjustment disorder per se will be like having a depressive reaction for more than up to 6 months. But there is another option given in your ICD 10 where it tells that if the patient is going to have an adjustment disorder, but it is not qualifying to call it as a depressive reaction, but it is exceeding more than 6 years, less than 2 years, 6 months and less than 2 years. So more than 6 months and less than 2 years. Again, it can be called it as adjustment disorder, but a subclassification of adjustment disorder as brief depressive reaction. Sometimes patient will also have adjustment disorder with depression and anxiety, mixed reaction. So all these things are subtypes of adjustment disorder. And you need to rule out generalized anxiety disorder, PTSD. The treatment of choices, again, SSRI is going to be the treatment of choice. Along with that, you can also give some cognitive behavior therapy where they will learn, mainly psychotherapy is given to learn how to deal with the stress, how to handle the stress. Okay, so with this, we are completing this question. Now moving on to the next question, the last and final question in the recall. A patient is brought to the emergency department with signs of opioid poisoning. What is the treatment of choice? So what will be a treatment of choice in this? Naloxone, naltrexone, fomepizole and flumazenil. So flumazenil. So all these four options are given in your exam. So what is the treatment of choice? What did you guys write? So most of them get confused with these two things, naloxone, naltrexone. So what was the choice you guys wrote? What is the choice you guys wrote? It is naloxone. It's not naltrexone. Remember guys, patient has come with acute opioid poisoning. So patient has come with acute opioid poisoning. When the patient comes to you with the emergency with acute opioid poisoning, you need to give a drug which is short acting, which shouldn't be a long acting. So when you want to give a short acting between naloxone and naltrexone, remember your naltrexone is a long acting opioid antagonist. Long acting opioid antagonist. So it does not have any role, antagonist, it does not have any role in an acute emergency condition. So naloxone is an opioid antagonist again, but that is going to be a immediate short acting opioid antagonist and it has a emergency reversal of opioid toxicity. So that is the right answer. Now coming to the second one, naltrexone. I told you, right, it is a long acting opioid antagonist. So mostly you will use it as a maintenance therapy. You will use it as a maintenance therapy. Okay. It is not used in the emergency condition. Mainly the main aim of naltrexone is relapse prevention. So mainly you use it for relapse prevention. Okay. Now coming to the fomepizole. Fomepizole is a alcohol dehydrogenase inhibitor which has no role in the opioid receptor. So it is irrelevant. This option itself is irrelevant. And your flumazenil, it is a benzodiazepam receptor antagonist. So this you give when you have a benzodiazepam overdose. Okay, not opioid overdose. Clear? Not opioid overdose. So now coming towards your opioid poisoning. So opioid poisoning usually when they present in your OPD, they will be presenting with the pinpoint pupil meiosis. The patient will have respiratory depression, CNS depression will be there. So patient will be like very drowsy, having a low GCS score, and often patient will have hypotension and bradycardia. Recently, I have been seeing a case which is admitted under our department with a opioid poisoning, and the patient is having all these features, typical features when the patient came. They all are, the patient had all these features like drowsiness, bradycardia. Patient will always be under 90/60 only. BP will be always maintaining 90/60. So patient will have a bradycardia. Usually patient will have 50 to 60 range of pulse rate. So all these things are typical features of opioid poisoning. Okay. So what do you give? So immediately if the patient has consumed 50 tablets, 60 tablets of benzodiazepam like tramadol, 50 mg of tramadol, if they are going to consume 30, 40 tablets and comes to you and you need to immediately reverse the problem, reverse the acute poisoning of your opioid. So what you do is you give a naloxone. Naloxone is a pure opioid antagonist and it has a rapid onset of action within minutes. So you can give either IV, IM, oral, subcutaneous, you can give various ways. So there are various ways which naloxone can be given and it temporarily reverses your mu opioid receptor effects and this requires a repeated dose. Why? Because it has a short action. Okay, moving towards the overdose treatment according to your Kaplan. So first task of overdose treatment is to ensure that adequate airway is there. Why? Because respiratory depression is the most common problem occurs. And once ventilated and mechanical airway management is done, then you give naloxone. Naloxone is administered at IV rate. So initially 0.8 mg per 70 kg of body weight. And there will be immediate increase in the respiratory rate, pupillary dilatation will be there. All these things you can actually observe in the patient. So that is exactly the importance of giving naloxone in an acute opioid poisoning. Whereas in a chronic maintenance, for a maintenance dose, you can use naltrexone, or as I told you, you can also go for methadone, buprenorphine. All this can be given. Symptomatic management, you can go for clonidine also, and maintenance therapy you can go for methadone, buprenorphine, naltrexone. Naltrexone is a mu antagonist which you need to remember, and mainly withdrawal symptom will be like pain, muscle cramps, and there will be a lacrimation, sweating will be there, yawning, patient will have profuse diarrhea. All this problem will be there. Okay, so opioid, papaver somniferum, most common abuse is heroin, but in a hospital setting, if you're going to see, people will also have this tramadol. So tramadol, illicit drug, if you see heroin, but our non-illicit drug, la opioid dependence patient goes is through the tramadol. Okay, so with this, we are completing the FMG recall sessions. I can proudly tell that out of 8 questions that are appeared in the FMG exam, we are very happy that 7 questions was discussed already in my in your GMI sessions as well as dopamine search sessions. So what I will advise you guys is kindly go back. If you are a subscribed user, just 3 hours. Okay, total duration is 2.5 hours is your dopamine search, and another 2.5 hours is your dopamine GMI. So 5 hours you can cover entire psychiatry. Psychiatry, as far as your NEET PG, FMG, and everywhere is concerned, you don't have to read in depth. What you need to know is the repeatedly they ask few concepts which I have highlighted in both the sessions, which has covered the entire psychiatry, which is required for your NEET PG, INICET, FMG, UPSC, whatever exams you go. This is the place where they concentrate, and mainly you need to know how to rule out the MCQs instead of reading the answers. Mainly you need to rule out the MCQ. That is the key mantra for all your short subjects. So I hope so that you will go back. If you are a subscribed user, go back, read, revise with those videos, and definitely I will tell you that if you have not attended everything right this time, after completing those 2 videos, definitely you will be able to attend 7 out of 8, because one question always comes out of box. Like this time they have asked about dissociative fugue. Every time there will be some out of box question. One question definitely chances are there, but remaining 7 questions you will be able to write. This happened even in your INICET May 2025 paper, where out of the 5 questions or 6 questions which was there in the exam, just the previous day I took dopamine surge class, where I have covered all the topics, and next day apparently the exam was attended by people from that session, and many reported to me that all the questions are covered already in the previous day session which was conducted by me. So what I will advise you is just be relaxed. Your memory needs to be consolidated. So always be relaxed. Always maintain just a consistency. Always try to consistently read something, attend MCQs. Okay, so by this way, you will be able to definitely get a good score. And I will definitely recommend you to always attend Dr. Vinayak Sandal sir's this motivation class sessions which he is taking, guidance mentorship sessions which he is taking. That will also definitely help you to know how to approach the exam rather than studying a lot, because 1 lakh people are attending every year and they also travel in the same path, like seeing videos, attending questions, MCQs, question banks. But you need to stand a little apart, a little distinct from them in order to achieve in your exams. So I wish you guys all the best in your exam. Thank you so much.